So thank you to all of our panelists. I'm sure you agree that we've learned quite a bit, even in this whirlwind tour. So we do have some time for a few questions. I'm going to just take the prerogative of the moderator to ask just a single question, and then if there are others, I'll invite you to come up. And one of the things that I was pondering, given where I'm from, so being from the southeastern part of the United States, one of usually the top 2 or 3 states in terms of highest rates of obesity, I know a few of you highlighted the fact that lower income, racial ethnic minority communities are often the ones that have higher rates of these conditions. But specifically thinking about this panel and engagement and community engagement, I'm wondering if maybe just one of you might speak a little bit about how your organization, your company has engaged that particular or those particular communities in your business solutions.
Thank you. So my name is Atif Bostic, Uplift Solutions. And so the way we engage community as it relates to that is, number one, meeting with them and understanding it, so having a conversation. And anytime we engage a project, the first thing we do are identify all of the civic leaders, all of the community leaders, and convene meetings to have conversations about what the needs are, what the concerns are, possible interventions, and then ultimately develop a plan. And then that work actually culminates in a larger town hall meeting where everyone from the community is invited to talk about the plans and the roadmap that was created, and actually have input into that roadmap as well. So it's actually not a final plan until after the town hall meeting has occurred, and we've gotten feedback from the entire community as it relates to what the impacts are.
Okay, great. And I think David might have. Well,
I'd jump in just from a more systemic level. The Indiana Minority Health Coalition and La Plaza are members of our leadership council, and we really rely closely in those partnerships to make sure that we're engaging appropriately. In our community demonstration project level, we have the Community Economic Development Organization in that specific neighborhood as part of the steering committee, and really relying on their existing relationships in the community to make sure that we're engaged properly and effectively and intentionally with the residents on creating solutions. The goal of these demonstration projects is not for us to come into a community and say this is what you should do, but to be a resource in that community to help the leadership there decide how it wants to attack the issues, and then to provide resources for them in that initiative, and to serve as a mini backbone, if you will, of their collective work in that regard.
I would just add that in the communities that we've worked in, we're a nonprofit that's based in DC and Cleveland, and we do work nationally. We've been invited in by those communities before we choose to work there, and we did work in Northwest Jacksonville, invited in by a coalition of basically, it's called iCare, Interfaith Community Action Resistance and Empowerment. It's a interfaith group of different clergy and faith-based institutions. And so in that process, we very much were trying to respond to what they identified as their primary need, which was the creation of jobs in this segregated part of the city. And so then from there, our work is really to think about how to engage the institutions in beginning to rethink their business practices to create pipelines into those communities in the areas of hiring, purchasing, and hopefully redirecting investment back into the local communities.
Start first here.
There's been a lot of talk today about zip code and health outcomes, and interestingly enough, there's been a lot of news this week about zip code and outcomes, and interestingly enough, Birmingham gets lifted up.
Yeah.
You know, that fine work that you're doing that's leading to less disparity by income and health. And I'm just wondering if there's any learning, fact-based learning, that you can offer on how those get magnified or diminished. What in the heck's going on in Birmingham?
You don't want to know. No, just fine. So, I mean, I think some of the comments that have already happened or been discussed from the panel, we similarly looked at what was happening several years ago in terms of life expectancy and infant mortality and healthy food access, and looked at things by zip code. But similar to a number of the models that were actually discussed here, we've several years ago developed a larger collaborative, a health action partnership in particular, which involves our United Way of Central Alabama, our county, Jefferson County Department of Health, and our local community foundation. And under that auspices, we've been doing community health improvement plans and allowed our community members to sort of prioritize our focus over the next several years. And they identified 5 different areas that include lifestyle development, advancing health equity. And so through a series of connecting with businesses, our Chamber of Commerce is very much actively involved. We have Bold Gold members, so leading CEOs and companies are at the table coming up with sort of individual or smaller level solutions that, as we're seeing, hopefully are trending in the right direction. So I think a lot of the answers are very much what has already been said today. So I'm going to go on this side. Nika.
Thanks. I think some very good qualitative studies and ideas. My question is based on some empirical data, which I'm keen to have, and maybe Elizabeth can tell me as well from Dallas. The question is no longer whether the zip code is related to health. That was settled 400 BC by Hippocrates in his book On Airs, Waters and Places, and has simply been restated by people over time. Absolutely nothing new about that. The question is, what interventions have materially changed that relationship? And what empirical evidence do we have of what really makes a difference? As far as I know, I would suspect they fall into a couple of categories. I'd love to hear your views. Are there examples of major infrastructure programs in a community that was depressed that have changed the health status? Are there examples of large-scale employment programs that were applied to a community that were very low on the health status that improved? And thirdly, are there targeted health interventions that make a difference? And on the third, I mention that because the first two are often very tough to do, yet there are plenty of good examples on the third, starting with effective tobacco cessation programs or effective immunization programs and targeted undernutrition programs. I mention it to try and move away from what has been a very general discussion about what is very nice to do and whatever in theory, but what has really made a difference to lower social class inequalities over time, and where's the evidence that this has really made a difference?
Derek, thanks for your question. Okay, so before in the presentation I talked about the importance of policies and laws in changing the environment. The reason I brought that up is because when you talk about programs and specific interventions, there's always a start and an end point of a program. Funding will always run out at one point. But the question at the end of the day is, how do you create an environment to normalize that everybody has access to the same opportunities? And are you focusing on the outcomes, not just on the opportunities? Because then the question is, are we talking about inequities or are we talking about inequalities? And so the problem with talking just about specific programs or arguing about who should get what when, the conversation always needs to be we need to level set the conversation of, does everybody have access to fair opportunities? And as you look at who, along the way, what are the social supports? And I'm not just talking about welfare, I'm just in general, what are the social supports to make sure that people have every opportunity, to, even if they trip and fall back or what life happens, that you can keep on moving forward. So when we talk about interventions, there is no perfect intervention. There's no perfect policy. We always have to talk about the inextricable link between health, income, and education. No one policy and program is going to be perfect. You can look at ROI and say, okay, for example, early childhood, the best early childhood programs, like when you think of the preschool program or Abercedarian one, you talk about the 8 to 1 ROI. That's really important because basically you're making sure that all kids have opportunity to high quality early childhood care and education so that it's much more likely that they're going to excel, and not just academically, but have the social emotional skills and health that they need. So I recommend changing the focus on what intervention's the best, but talking about how do you make sure that the return on investment from from human development, from prenatal to career, that social structure is in place to make sure that everybody wins and everybody has a chance. If you want examples of things that are working, if you look at the Robert Wood Johnson Foundation funds the Build Healthy Places Network. If you look on buildhealthyplaces.org, they have a lot of different examples of what is working. If you look at the What Works for America, it's a publication that was partly produced by the San Francisco Fed. And the idea was talking about what do we actually know is working in these communities where there's generational poverty and where there's concentrated poverty. So we have to talk about the systems approach. What we do know works is you have to have a people and place-based approach. You have to make sure that everybody has access to quality education from cradle to career. It means you have to have braided financing. You're not going to have just funding or just financing. It's that whole sphere, like you were talking about, that whole spectrum. You have to have collective impact, that nobody can do it on their own. It's about both the public health, healthcare, community development, economic development sectors working together and measuring. If you look at a logic model, say what are the inputs, okay, what are the outcomes, short-term and long-term, but then what's the impact? And if you have a collective impact model or approach, everybody's going to be working towards the same goal and can see who's doing what, where are their gaps, and what needs to be improved upon.
I guess I think that was wonderfully said, Elizabeth. But I think what I would add to that is that I don't think anyone's really tried to measure the core or the actual impact of a specific inclusive and equitable either jobs program, and then align it with then thinking about how do we actually lay over that impacts to shift the healthy practices, and then to measure that over a period of time in which we could actually again begin to track that impact, because it's an incredibly difficult social experiment to, I think, try and to tackle. I think you can do it very easily, or much more easily, for specific health interventions around diabetes or obesity or whatnot. But what you can tell, I think, and from the work we do is, and I think community development in general has focused on, is outputs, right? It's been focused on jobs created, units built, because that next level of layering in a health perspective is pretty new. I think the beginning to build the relationships between the community development and public health and healthcare sector is still, it's really a conversation over the last 5 to 10 years, and I think our desire sometimes to see immediate results in issues that have been built up and embedded in communities for as long as this country has been created is we have to really think about what are the systemic barriers that we're trying to break down. And so I do think that we can look at the changes around healthy behaviors, but I think we're going to hit a wall if we don't begin to think about some of those underlying economic and social inequities that are present in many of our communities, and that can really dovetail with these broader strategies and be part of the solutions that we look at. Just briefly, our work in Cleveland, it's nascent. It was, again, could we create local businesses that would provide goods and services to the healthcare and universities, that would employ local residents that had barriers to entry, and a good 60% of the people employed have criminal backgrounds. These would be businesses that would survive in the market. And today, there are 3 businesses. They employ more than 120 people and none of those people in those communities would have had jobs at these businesses if it wasn't for this effort. And there's a wealth building piece. Now, once you kind of stabilize the floor, I think you can more effectively layer over some of the changes, hopefully in creating healthier workplaces and addressing some of the other supports. But I think that it really is going to take an all-in approach to really bring back some of our communities and create the health and well-being that we want to see. And to the comment, though, that was kind of pulling apart the zip code, business. And the New York Times article, I think it is notable that between, even in the communities they highlighted as being the most advanced, there was still a staggering difference in life expectancy between those in the lowest income brackets and those even in medium to upper middle class brackets. So that gap is even in the best performing communities is still wide. It's good to know that it's narrower in some communities, but it's still wide.
So I think we're going to actually pause on that in the interest of time, but I think this is a nice segue to that third panel where we're going to really talk about what are the opportunities and what are some of those barriers and challenges. And what I've certainly heard in this last discussion is, a need to have some common language. So when we talk about success, it may mean very different things for community members, for small companies, for larger companies, and for the public health arena. We also want to talk a little bit more about measurement and how do you measure, once we have a definition that we agree upon, how do you measure that? And then also how you interpret those findings. Even in this last discussion, different people might have reviewed that same amount of data very differently. But now I'm going to turn it back over and we'll have a pause for lunch.
So we are going to adjourn until 1:45. We'll pick back up here at 1:45, and we will have, again, all of the previous panelists now with an opportunity to color somewhat further outside of the lines of what they've already presented and talk about the barriers in response to questions and to each other. For the members of the roundtable, we will adjourn and go directly back to the West Court. For everyone else, you're invited either to use the cafeteria here or take nourishment some other place, some healthy nourishment nearby. We will, for those who are interested, and that I hope includes everyone, in some exercise, Kathleen Tully will bring us together out here in the front of the building. In the front means you can see the Lincoln Memorial, then you're in the front. If you see the State Department, you're in the back. So if you're looking at the Lincoln Memorial, Kathleen Tully will gather us there at 1:15. At 1:20, she will start out on a walk, which will make up for all of the sitting we've been doing. Because they're coming back and you'll be able to thank them more fully, just modestly thank our panel now, and we'll do more later.